My name is Diamond Fernandes. I'm your founder and director of the Heart Fit Clinic, and I'm here with Dr. Yaariv Khaykin, and he's from Ontario, and he's an electrophysiologist as a cardiologist. So welcome. Yeah.
Thank you so much, Diamond. And it's great to have everybody here.
And what I'm going to do today is talk about what's new in remote heart monitoring, why we monitor, and the advent of textile computing, or a more comfortable way to monitor your heart. What is the rationale for monitoring modalities, and our approach? First, I wanted to show you where I work. So what you see here is the South Lake Health Center in Newmarket, Ontario, just north of Toronto. And our clinic, where we actually see patients before they undergo procedures and after procedures, is on the 6th floor of this medical art building, connected by this beautiful walkway, which has been featured in a number of movies. And our clinic is PACE Cardiology. At the hospital, we have 5 electrophysiologists. These are cardiologists like myself, the electricians of the heart. And we work out of 3 labs that allow us to do over 1,500 procedures per year, of which roughly about 1,000 are ablations for atrial fibrillation. We also do about 1,500 devices per year. We have a number of different systems. We perform procedures using 3D electroanatomical mapping and have the cutting-edge technology to allow us to do that. We also have the newest technologies, the pulse field ablation technologies, and essentially we have all of the technologies that are on the market right now and have worked with a number of other technologies in research studies. We implant defibrillators, we implant pacemakers, we extract leads, and we also place these left atrial appendage occlusion devices to prevent stroke in appropriate patients. As far as the PACE Cardiology clinics, we've got 3 locations north of Toronto, about 30 cardiologists.
Huge clinic that went to there. It was like so many people and a couple floors you were on too.
Yeah, it was great to host you there. We see over 200 patients a day through the door at the clinic in Newmarket, which is our busiest location. Yeah. And we also offer virtual medicine. Essentially, we offer virtual medicine anywhere. We turned on the gates for that, I believe, March 18, 2020. The pandemic really streamlined our approach to be able to do it. And we use both in-clinic care and virtual medicine for all of our pre- and post-ablation care.
Now, let me switch the gears to the core of this presentation. Why is it that we're monitoring? And, what do we do with that information? Well, the most common reason to monitor somebody is to diagnose their problem. Mm-hmm. Patients come to you and they complain of dizzy spells, fainting spells, fluttering, palpitations, skip beats.
But, there are a number of different things that can produce the same kind of symptoms, and we can't treat it based on the history alone. We need to be able to diagnose and understand what the ECG shows, what the rhythm is that corresponds to these symptoms in order to provide guidance as far as what the treatment for that should be.
Now, we also have a number of patients who we know have arrhythmia, but the amount of arrhythmia, the burden of arrhythmia, and the type of arrhythmia that they're experiencing may be changing over time. Mm-hmm. And so monitoring is important to determine that burden. In patients with conditions like atrial fibrillation or flutter,
we know that when the heart goes too fast for too long, they may get into heart failure, they may potentially have a heart attack, and we need to be able to monitor them to see if they're adequately rate controlled, if their heart is not too fast, or on the other hand, if it's not too slow, and maybe they need a pacemaker. And then we need to monitor patients who are coming in with conditions like an unexplained stroke. So every so often we see, perfectly healthy young patient comes in and their first presentation is stroke. Well, there are a number of things that can cause it. Mm-hmm. Well, one of the common things that causes it is a condition called atrial fibrillation, and that's primarily what I treat. And you can't always pick it up with an Apple Watch or an ECG. Sometimes you need to monitor a patient for a number of days, weeks, or months before you can pick up an episode of
atrial fibrillation. I wanted to show you, a number of studies have been done, and they've been led by actually a group of electrophysiologists right from here in Vancouver.
Yeah. Where in one of the national or multi-center studies that we've participated in as well, patients were implanted with a monitor. We have these little monitors, implantable cardiac monitors or implantable loop recorders. Yeah. What they are, they're about like a little USB stick with 2 electrodes at the tips and a battery and an antenna. And so we can inject it under your skin, And every time it sees an abnormal rhythm, it records about a 2-minute episode on average, and it has memory for about maybe 10 or 20 of these episodes. And then when you're around an antenna of some sort, some of the companies put it on a phone, some of the companies give you a device that plugs into the wall. This monitor transmits everything that is recorded, okay? And it's considered to be the gold standard just because it's monitoring, for years continuously.
Yeah.
But, it's invasive. You end up with a scar on the chest. You have to come back for a repeat procedure to take it out. So it's not necessarily, panacea. However, in this study, what they've done is they've recorded all of these episodes of arrhythmia with an implantable monitor. And then they modeled and they said, well, what if we break up this time into 24-hour chunks, 48-hour chunks, 7-day chunks, 14-day chunks, and we kind of move those windows up and down. How much arrhythmia would we have picked up if we monitored that same patient using conventional external monitor?
Yeah.
And what this shows is in blue is a 24-hour ECG, 48-hour ECG, 7-day and 14-day monitors. And so the sensitivity of picking up arrhythmia with a single monitoring session. So if you have a single 24-hour monitor, you're going to pick up about 10% of the arrhythmia that you would have picked up with an implantable cardiac monitor.
So let's rephrase that in a different way. So what you're trying to tell me is that if I'm monitoring a heart rhythm for 24 hours, I'm only going to pick up 10% of what actually is happening.
Correct. Right. So,
and that's going to your cardiologist, getting a proper monitor and seeing.
Exactly.
Yeah.
And so it's like, check, you've had your monitor.
Yeah.
Okay. Well, did it show anything? No.
Yeah.
Was it going to show anything? No. And the problem is with a lot of these traditional monitors, they also have these sticky electrodes and wires. People don't want to wear them for more than a day or two. Now, if you move to a 14-day monitor, you're picking up about half of the events.
So as you can see on the screen there, if I'm looking for someone for 14 days, at least I'm going to get half of it, is what you're trying to show.
Correct.
44.5% there. Yeah.
And then what each of these points shows is that as you repeat these sessions, so if you have, 2 monitors, 3 monitors, up to 10 monitors, your pickup does go up, whether it's 1-day or 14-day monitors.
So looking at those 14-day monitors many times is what.
Correct. Exactly.
Yeah.
And so the other way of looking at it is, again, looking at, if you're looking at a success of a strategy to get rid of arrhythmia, right? In this case, with an implantable cardiac monitor, success rate, in the long run was about 52%.
Yeah.
Okay, and this is now a few years ago with a technology we don't necessarily use very much anymore, right? But if these same patients just had 24-hour monitors, at the end of the day, they would have been told that the success rate was 92%.
Yeah.
Because you missed all the events that you would have picked up if you had an implantable monitor. It gets pretty good by the time you get to a 14-day monitor. So with 14-day monitor, while your implantable monitor would have given you a success of 52%, it would have been 69% with a 14-day recorder.
Yeah.
Okay, so again, it gives you an idea that the longer you monitor,
the better it is.
The better, it's commonsensical, but it just shows it a little bit better.
Well, yeah, and in Alberta, where we have some of our clinics as well, is that 48 hours is the max that you could do. Right. And you can see that that's just not great.
And just not great by comparison.
Yeah.
Now, success rate of these procedures also obviously depends on what you define as success. And so what this shows is if you define a failure as any episode of arrhythmia under 2 minutes, you're going to have a lot of failures. But if you're going to say that you need to be out of rhythm for 24 hours or more before it's a failure, then your success rate is obviously a lot higher. So when you read papers or you talk to your cardiologists, your physicians about success rate of this or that intervention in the electricity of the heart, this kind of minutia is very important. It's very important as to how, how we're looking for failures, whether it's a 24-hour monitor or continuous telemetry or an implantable monitor, and what do we define as success? There you go. And we know that with atrial fibrillation, the longer the episodes and the more the burden of the arrhythmia, the more likely you are to go to the emergency department, get hospitalized for it, need to get a shock, need to get a repeat ablation procedure if you've had an ablation procedure for it. We know that the longer the episode, again, the more likely you are to have a need for cardioversion, electric shock, or repeat ablation procedure. The greater the burden, again, the burden and the duration of the arrhythmia correlates with your quality of life, how badly you're doing, and how likely you are to need to use the healthcare system.
So how can you monitor? Well, there are consumer-level devices like your wearables, your Fitbit, your Apple Watch, or your Samsung Watch.
And then there are medical-grade monitors. trans-telephonic monitor is kind of really older
technologies, but in a way similar to a LifeCore. Holter, we'll talk a little bit about that, as well as the newer
Holters that involve a little
patch. Mobile cardiac telemetry, that's a service
that's available in the US, not available in Canada, when somebody is actually monitoring you continuously from a monitoring center. Implantable loop recorder, so those implantable cardiac monitors and other devices. So if you happen to have a pacemaker or a defibrillator, they have all the functionality of being an implantable loop recorder. They also record all of your rhythm abnormalities. And I'm going to talk a little bit more about technology I've been working with very closely over the last couple of years, that of textile computing implemented by a Canadian company called Myant. So many, if not all of you, have Apple Watches. As you know, Apple Watches are really good at watching your heartbeat. And a few years ago, there was a very large Apple Heart study where participants with an Apple Watch were offered to participate in the study. And when the device detected abnormal heartbeat or irregular heartbeat, they could wear or record a quick ECG, send that ECG in, and then they looked at correlation between the Apple Watch detecting what it thought was atrial fibrillation and the ECG, showing atrial fibrillation. Pickup was about 34% overall in that study.
That means it was picking it up 34% of the time?
Well, the way I interpret it is, so first of all, only about 2,000 out of 400,000 participants got notification of an irregular pulse, right? Then those patients who got a notification could then get an ECG. The ECG was not necessarily concurrent with a notification, which I think is one of the kind of methodological problems in the study, is that...
So Apple Watch we can't really rely on is really what I'm trying to... I mean, it does give us something, but
probably better than that, because of the study is kind of underperformed in a way because of the way the study was structured.
Of course,
but it's not, a medical grade device.
I wear a little ring here, so that kind of picks up electrical imbalances too, right? So it's kind of different things and modalities that you can use, right?
So, right, and I actually just pushed out a paper on LinkedIn today, where I talked about the different modalities, ECG versus, the ring or the Apple Watch would use photoplethysmography, would use a little light that it's showing, similar to an O2 sat monitor in a hospital, that tells you what your heartbeat is, and then you can apply algorithms to that, looking at irregularity, and it's going to err on the side of calling it AFib versus not calling it AFib.
Of course,
So I find, I have the same on my Samsung watch, and sometimes it tells you have AFib, but you don't actually, And now the newer version of these watches, this wasn't available at the time of the Apple Heart study, but the newer watches all allow you to take a little quick ECG by running an app and then putting your finger on the crown, completing the circuit that gives you what we call lead one. That ECG is very good quality.
Of course.
Right? But it's not monitoring that ECG. You only get that ECG
when you actually
do it, right? So you're not getting a continuous ECG with that device, which is an important differentiator. And this just shows you pickup compared to an implantable cardiac monitor. So depending on the lengths of the AF episodes. So episodes under 6 hours, 6 to 12 hours, 12 to 24 hours, more than 24 hours, the patient has an implantable monitor. Here is the pickup of an Apple Watch, right? So again, it's going to miss a lot of episodes, is the bottom line, right? It's going to pick up some, but it's going to miss a lot of episodes. Now, a study of an AliveCore device, many of you are familiar, you can get these on Amazon. They come as
fingers on it.
You put your fingers on it, records an ECG. It's the exact thing. It's the exact same idea, using pretty much a very similar algorithm to the one used in the Apple Watch to record a lead one. It's very good quality. A number of my patients are doing it and sending me, faxes or emails with that ECG. And they can also analyze that ECG strip and tell you with some certainty whether it's AFib or not. It's been compared to a medical grade trans-telephonic monitor, which the correlation in detection between the two was very similar, was very good. But essentially, a LifeCore is a TTM of sorts. All right, now. Why is episodic monitoring not that great? Well, we know that a number of patients don't have symptomatic AFib. They have AFib in the middle of the night. They have AFib when they're not feeling it. So they're not going to put their finger on the dial. They're not going to record an ECG. We did a study at our center where we monitored patients with implantable monitors following ablation, and we looked at correlation between sort of symptomatic versus asymptomatic episodes. And 12% of the patients after ablation only had asymptomatic episodes. They had no symptomatic episodes at all. So if we're relying on a device that's going to let the patient check their ECG when they have symptoms, it's not going to work. And we know that in these patients, the ratio of asymptomatic to symptomatic episodes goes from 1 to 1 before ablation to 3.7 to 1 after ablation.
Now, continuous monitoring. So,
this is the picture that you get with your traditional Holter. You get these stickers on your chest. We need to shave the hair of your chest. We need to scrub your skin to roughen it up, to improve contact. Most people don't enjoy it. Then we have to make sure that these things don't fall off and you get a continuous recording of your ECG. This gives people hives, allergies. I've had patients, where skin was literally bleeding after these monitors. And again, unfortunately, the longer you monitor, the better the result, and those two kind of don't go together very well. This is a picture of one of these implantable monitors that are injected under the skin. And then this is a newer version kind of a Holter. It's just a single patch. Zio iRhythm patch was the first one out. There are a number of these, including a Canadian version called Isentia from Quebec. Most of these are essentially, again, a USB stick with a battery, with a couple of electrodes that record. Most of them just record a single ECG lead. There are some newer ones that have a bigger patch, that have several electrodes, or that have additional wires with similar connectors that connect up to the patch in order to record other electrodes. So a little bit better than this, perhaps, but more expensive in a way, and still needs glue, skin prep, etc. So these monitors are generally expensive. They're expensive consumables from the point of view of running the clinic. MCOT is not even available in Canada. That's kind of continuous monitoring with somebody actually watching the monitor. And implantable monitors are invasive. Most people are not going to want to have this thing injected under their skin. And the injection honestly takes about 5 minutes under local anesthetic. It's not even that big of a deal, but the scar stays, doesn't go anywhere. And when you want to take it out in 3 to 4 years when the battery dies, it's a slightly bigger procedure because the monitor actually has this tissue ingrowth plate to make sure you don't put it in the chest and it ends up in your belly. So the tissue grows into it, and so I have to make a slightly bigger incision to then fish it out. Not pleasant. And compliance is not great. You have skin reactions to the tape. You can't shower with a lot of these monitors. It limits your activity. You don't want to go to big events like weddings, and such. So a Myant monitor is the next thing that I'm going to talk about. Back around 2014, 2015, knowing how many patients were monitoring and how many were complaining about the traditional ways of monitoring them, I started to actually actively look for a partner in the industry that was able to produce a device that would allow us to monitor patients comfortably using dry textile electrodes, essentially electrodes that are effectively built into your clothing, that would also allow us to monitor you for a long time. And this slide illustrates it. In the most common and easy implementation, it's a band similar to your garment or polar band that you would wear on your chest when you exercise. This one you can wear both during the day and night. The electrodes are part of the fabric. They're essentially part of the conductive yarn. And there is a little pod that goes into a little pocket on the outside of the band. The pocket has the electronics, the battery, the transmitter. And the way the system works is there are 5 electrodes that produce 3 clinical grade ECG channels. Then the ECG gets sent from this little pod to your phone, and from the phone into the cloud. It's all private. It's approved by Health Canada, currently pending FDA approval. And it allows us to use it just exactly like a Holter, except you don't have to shave your skin. We don't have to prep it. You can wear it whenever you feel like wearing it. You can take it off and shower. The battery in the pod is good for about 72 hours. And so
it's very quick to charge.
And it's very quick to charge. So the ideal workflow that we tell patients is in the morning when you go up to shower, take it out, put on the charger, shower, put it back on. By the time you finish showering in 20 minutes, give or take, it'll charge enough to last you a couple of days. We have done studies at our clinic where we validated recordings in over 700 patients, We put bands as well as there are other wearables using the same technology, and we validated correlation with conventional leads between the leads we get from the band. We also got feedback on, the comfort levels from the patients. We tested them, with the patients walking around, going on treadmill, laying down, sitting, et cetera, to make sure that it actually produces useful signal, and it does. The signal is sampled at about 1,000 hertz, over 300 hertz per channel, and it produces a fairly clean ECG. We did a study then where we had patients wear a conventional Holter as well as a Myant Holter at the same time. And we wanted to see, are the recordings identical in terms of arrhythmia pickup, estimates of your heart rates, etc. And what you can see here is correlation between a conventional Holter at the bottom and the Skiin Holter, the Myant Holter on the y-axis. This is correlation for the slowest heart rate, average heart rate, and fastest heart rate. And you can see that those are very, very, very close, essentially identical. Now, we did lose a bit of time. So with a standard Holter, we've got about 23 hours per day worth of signal, clean signal that could be analyzed. With a Myant monitor, we've got about 16 hours. Now, we looked into this further, and what we found that about 2/3 of the time that was lost was due to the patient simply not wearing it, because it's so comfortable, you can take it off, and then if you decide not to put it on, obviously we're not detecting anything. About 1/3 was due to noise. And to minimize noise, these are dry electrodes. We recommend or really ask our patients to use some lotion under the electrodes, or work out. When you work out and sweat, that significantly improves the contact between the electrodes and your skin. If you put some lotion on it, it significantly improves contact. And then the new version of the monitor that we're using right now, that number is significantly better. It's over 20 hours.
When you talked earlier about how long it actually picks up for in a 24-hour duration when you actually do a monitor, so you said it only picks up so many percentage of the time. Was it 30% of the time?
Correct.
So,
well, it picks up 70% of the time. It is important, and again, if you use lotion, if you set the band a little tighter, the amount of noise you're going to have is less. We've had patients exercise on treadmill up to 6 miles per hour with very little, if any, noise. So we know it can be controlled. It's then to some extent up to the patient as to how they wear it, if they wear lotion, etc.
Of course.
And we do have a customer support center that Myant organized, where if the signal that we're getting is not ideal, we actually let the patient know and ask them to make modification, make changes, put lotion on, make it tighter, et cetera, to try and improve signal detection. But, the important thing is when we actually looked at the ability to pick up actual arrhythmia that these patients were having, and we looked at atrial fibrillation and flutter, extra beats coming from the upper chambers, extra beats coming from the lower chambers, the time when the patient went slow, correlation was perfect. So there weren't any patients who had AFib, let's say, with one monitor and we didn't pick it up with the other.
Gotcha.
So even though we didn't pick up 100% of the time, we picked up all the relevant clinical events.
And then, of course, that data improves over, let's go back even to when you started, it improves over 14 days or longer time.
Exactly. So the longer you wear it, right? And theoretically, there's no time limit. You can continue wearing it indefinitely. These bands are fully washable. You can throw them in the laundry. They've been approved for up to 50 washes, 50 cycles. And typically when one of our patients gets a kit, they usually get, I believe, 2 or 3 bands in the kit anyway. Which is certainly enough for a 14-day period, and more are available from the company. And so these are comfortable, no shaving, longer continuous monitoring, and again, they can be set up in clinic or just simply mailed to you if we know your size. Great benefit to the clinics. The clinic doesn't have to, buy a lot of expensive equipment. It can spend more time on actually looking after you than the technical side of it. One exciting thing that we're starting to release shortly is this, is a new app for the patients. So with a new app right now, to start using it, all you have to do is scan a QR code. Once you have the kit, you have to scan a QR code that identifies you on the system. As a patient, it tells you how much data you're collecting and how much of it is good, how much time you still have left, kind of a progress bar on your Holter, to collect the data we need. You can see your ECG through the app. And then on our end, we can analyze your ECG. We see a clinical grade ECG recording right here that, in this case, showing atrial fibrillation. We can also look, it's not all, I would like to think it's all about atrial fibrillation, but it's not all about atrial fibrillation. There are other arrhythmias, like extra beats that are coming from the lower chambers. Is a relatively common arrhythmia. And most Holter monitoring systems can't tell you if somebody's having kind of a lot of the same extra beats or if they're having extra beats coming from everywhere.
Yeah.
And it makes a difference. If you have a lot of extra beats that are coming from different parts of the heart, they're a little harder to manage. If you have a lot of extra beats, but they're all coming from the same part of the heart, we can actually go and zap that as well with one of our catheters. And so with the Myant system together with a Holter package, we can actually see different morphologies of the PVC, which makes a big difference compared to a lot of the competition. We get a lot of data on heart rate variability, probably near and dear to you, and what you do as far as stress management and kind of heart health in general. We get data on your QT interval. So patients who are at risk for long QT take medications that may prolong long QT. We get that data from the recording as well. The center that's monitoring you, the customer support center, can see how much data you're collecting, how much of it is good quality, and again, can contact you if we're not seeing good signal coming from your device. And we're about to release these irregular heart rhythm detection. So right now, yes, you can see the ECG, but right now the device doesn't tell your phone, doesn't tell you if you're having AFib. I know, and I can tell you after you've had the Holter monitoring session, but the device doesn't. And to kind of complete that circle, we're about to release an irregular rhythm detection report or heart health report that the patient will be able to see on their phone. And what that report is going to tell you is it's going to tell you your heart rates. It's going to tell you if you're having atrial fibrillation, what your burden is, if you're having AV block, if you're having PVCs, if you're having other arrhythmia. And it's also going to let you trend your factors right through your app.
Yeah.
So kind of empowering you to participate to a greater extent in your health. And then something that's really kind of near and dear to us on the continuous ECG monitoring. And, I tell you a little anecdote. I had a patient who was wearing one of our monitors, and she was about halfway through it. She had a fainting spell, and she came to the hospital while I was on call as a cardiologist. I still do that every so often. And she told me when she had her fainting spell, I pulled up my laptop, opened up the portal where I can see full disclosure of everybody's ECG, and right in front of her could see, here, when she had the pause, that's when she fainted, we got the diagnosis kind of like this immediately.
Yeah.
So really cool way of doing that. What's hidden away right now is the pod also monitors your activity, your steps, your sleep stages, your respiratory rate, and your body temperature. And coming soon in the next generation of the device, we will have slip and fall detection, oxygen saturation, blood pressure, and improved sleep and respiratory tracking. The other thing that's really cool is that the application, the new version of the application, will allow you to share your biometrics coming in with your circle of care. So for instance,
and this is how we would like to kind of use it, is from a cardiac rehab perspective, is that if someone has a heart event, they want to make sure, am I okay? That's the biggest thing that people have, because when they leave the hospital, cardiologist says, okay, bye, I put in your intervention, whatever it is, and now it's like, I'm at home, now what? And this is where cardiac rehab is so important, and this is where devices like this are a game changer to really monitor and give peace of mind to the patient, to say, hey, you're good, or you're not, we got to do some more, whatever it might be, right?
And to just capitalize on the peace of mind, imagine if you have an elderly parent, right? And if you can get an alert through the app, if they fell, if you can get an alert through the app, if their heart rate is too fast or too slow, if their breathing is too fast or too slow, if they have a fever, without necessarily being there. So long as somebody is wearing it and they've shared their data with you, as their child, you'll be able to see what's going on with your elderly parent. It's quite amazing.
It's impressive that way. So, and that's where I'm getting excited about it from that perspective. Is just a long-term way of monitoring your rhythm I know looking for ischemia, meaning lack of blood flow, is a little bit more challenging. We're only getting one lead, but it still would tell us, hey, I'm getting chest pain and seeing
We're getting three leads. We're getting three
Yeah,
leads,
so
but still, yes.
but it's still, that's better than nothing, right?
Exactly.
Like, a lot of things have one lead systems and they're not that accurate. So this is where I'm getting excited about it from a cardiac rehab perspective to be able to monitor.
And from the point of view of your rehab specialists who are working with the patient,
Yeah.
they will also be able to have this kind of view, where for each one of their patients, they'll be able to trend their rest rate, their heart rate variability, and these other parameters over time, and see if the patient is kind of staying within what would be considered their baseline or deviating from that baseline in any way.
Yeah.
So I think that's going to be very helpful in that way.
And especially for patients that are on beta blockers, some of them don't need it, some of them need more. Like, this is a great way of being able to monitor.
Well, and with blood pressure, blood pressure, heart rates, I see patients and they take all of their medications in the morning, right?
Yeah.
And then you monitor them with one of these and you see that the heart rate like super fast in the morning and it's super slow at night.
Yeah.
The same goes for the blood pressure.
Yeah.
The blood pressure is really high at the beginning of the day and then, there's no blood pressure at night because all of these, 5 medications for the blood pressure are all on board.
Yeah.
And it makes it so much easier to rebalance these medications. Take some in the morning, take some at night. Maybe you don't need all of them.
Yeah.
Etc. Exactly as
So,
you're saying.
And it's not your fault. I mean, when you see people in the hospital and you're prescribing this, it's like in an emergent situation. You've had this situation, and you get that regular. Everyone gets that regular cocktail, but to personalize it, this is where I think this is going to be super valuable.
And to be honest, the other thing that's very important there is compliance. Not necessarily all of our patients actually follow our advice. This allows you to really get the metrics, understand compliance better, understand what the patients actually need. They need those medicines, they don't need those medicines. No point you doing it if nobody is sort of following your advice. It works both ways, obviously.
Yeah.
And the next thing that we're working on, a couple of things. One is Myant is going to come out soon with this Cares 360 package, where if somebody wants to just, if they're not your patient or my patient and they just want to be monitored, that's going to be something that people will be able to order online. But the big thing that we're really going to want to work on in the next little while, and we have a grant, we're working on it with University of Waterloo, is to develop data-driven, AI-enabled prevention algorithms. Yeah. We want to see, can we take all of these multimodal biometrics that are now coming from this device, potentially other third-party devices, can we tell ahead of time if you're going to have a heart attack, if you're going to have a stroke, if you're going to go into heart failure, if you're going to have atrial fibrillation? The research in this area is quite phenomenal. There are companies now that have been able to validate AI algorithms that, based on an ECG and an O2 sat monitor, can potentially diagnose you with coronary disease, pulmonary hypertension, aortic stenosis without imaging. Now imagine you supplement all of that with continuous monitoring, with very rich signal in that ECG. Potentially we may be able to get a lot more data from it.
Yeah. No, it's powerful for sure.
Anyway, I think this is all I was going to talk about from the monitoring perspective. I'm more than happy to show a few slides on ablation if you like.
Yeah. So before I get into that, I really like the ablation side of things. I just want to come back to the question I had earlier. And when we talk about how we treat this, the first option is medications. The next option is then cardioversion, and then the next option would be then ablation. Right. And so when we talk about medications, if someone's not in AFib all the time, I find compliance is not that great, and rightfully so, because they're not in it. So maybe I think that would be my first question. If someone's not in it all the time and they're asymptomatic, I don't know, maybe their AFib burden is under 10%, whatever might be the situation. But when you look at their CHAS-VAS score, which is, hypertension, their age, their diabetes risk, stroke risk, all that part of it, then, what is your criteria for that? Because a lot of people come and see us and they're like, okay, well, I don't want to be on that medication. And you look at the number needed to treat on someone that is not really in it often. This is where continuous monitoring is really valuable for that patient.
Right. For sure. And, the problem is we don't know how much arrhythmia is enough arrhythmia to put you at risk. We do know that more arrhythmia is worse. So we know, and I showed you some of those numbers.
Yeah.
If your burden is greater, if the duration is longer, you're more at risk for having, both symptoms and clinical events that lead you to go to the hospital,
Of course, yeah.
The problem is that, from the studies, we know that an episode as short as 6 minutes, still correlates with higher risk of stroke. But monitoring is certainly important in terms of understanding trends, understanding, where you are now, where you're going to be, down the road, and triggers. Why is your arrhythmia all of a sudden? Why are you having more arrhythmia? Why is your burden greater? Why is your heart rate faster?
Maybe if I can ask a second question in there, why do people end up with arrhythmia?
Well, so there are a lot of kind of well-known kind of clinical correlates to arrhythmia. To be honest, when patients come to talk to me about it, before I even dive into medications, I always talk about, what can they do? What is in their lifestyle, what is in their ability to do to change, the course of the events. So hydration is very important. If you're underhydrated, a lot of people are out there, drinking lots of coffee and not enough water. That type of lifestyle is not great from the point of view of fainting or syncope, as we call it, or arrhythmia, PVCs, et cetera, et cetera. And, I have a few of my champions, who are coming in either with fainting or atrial fibrillation. I have, a guy came in and said, I drink 15 espressos a day. And he came in with atrial fibrillation. I said, well, if you're going to be drinking 15 espressos a day, you're going to start fainting as well. I said, well, I've been fainting for a long time, but it doesn't bother me nearly as much as atrial fibrillation. I had a real estate agent who was sitting next to one of those drip coffee machines. He was drinking 4 liters of coffee a day.
Wow.
Right? So it can be done, but probably not great for you. Okay. So we typically recommend as little caffeine as possible. Aim on average person needs about 2 liters of non-alcoholic, non-caffeinated beverages a day. Very simple. If you exercise, you need more. If you don't, maybe you don't need quite as much. If you're a little older and you have heart failure, maybe talk to your doctor. Alcohol. Definite correlation between alcohol and atrial fibrillation. We even have a name for one of the ways it correlates, called the holiday heart syndrome. That's when you have a few drinks over the weekend, you come into the emergency room on Monday morning with atrial fibrillation. It doesn't mean you're going to ever have it again. Necessarily happens a lot in young people. So we know that having a binge increases your risk of having an episode that doesn't necessarily repeat itself if you don't do it. But we also know that if you have greater than reasonable continuous intake of alcohol, your chances of having atrial fibrillation are greater, and you're also underhydrated over the long run. Weight is a big contributor in a number of ways, right? So really, all of our clinics should target weight before we target anything else. Being overweight puts you at risk for diabetes, high blood pressure, high cholesterol, heart failure, stroke,
you're messing around with the metabolism of
you're messing around with everything. And specifically, if I'm going to put my blinders on, yes, there's lots of evidence, both animal evidence and human evidence, that gaining weight increases your risk of atrial fibrillation, losing weight reduces your risk of atrial fibrillation. That correlation is clearly there. And in fact, I'm sure you're running programs. We've run a program called Ideal Protein years ago, which was a keto diet, and we've seen significant number of people whose requirements for medications for a number of these conditions have come down. Their arrhythmia management had improved. This day and age, a lot of it is about using the GLP-1 medications.
Of course, all over the conference this year. I don't think I've ever seen it advertised so much before.
Right.
This was the first. Mind you, the study just came out in 2024 early, right?
So interestingly, we participate quite heavily in research studies, and we participated in STEP-HF and STEP-Diabetes, which were studies with Ozempic. And in STEP-HF, these were patients with heart failure, who were overweight, and as they lost weight, their heart failure, got better. And atrial fibrillation was kind of not even a secondary endpoint, it was like a tertiary endpoint, and they didn't really look at it very carefully. So they didn't really focus on AFib. But even without focusing on AFib, they found that however which way they defined atrial fibrillation events, they went down by 50% in the patients who lost weight. So clearly makes a big difference. And another way that it makes a difference is through sleep apnea. If you're overweight, you're going to be more likely to have sleep apnea. If you have sleep apnea, you have these surges of adrenaline, noradrenaline. When you stop breathing, your body tries to wake you up. You're not getting enough rest. You're not getting enough proper deep sleep. You're getting the surges of hormones. Your blood pressure goes through the roof. You're at risk for stroke from the blood pressure changes, you're at risk for stroke from atrial fibrillation that you can get. So sleep apnea, clearly correlation with atrial fibrillation, independent potentially of the weight.
Well, that goes on that side of things. And I always talk about hormonal imbalances there, right? Especially with women with perimenopause or menopausal symptoms, or even for males, like if there's any hormonal imbalances, stress, like those things can affect that rhythm of the heart, right? So that's not sleeping well does that. So
and anecdotally and empirically, lots of patients come to me. I've had a number of patients who have had palpitations or arrhythmia around their periods, for instance, right? But it's a bit out of my kind of comfort zone as far as, I don't know from the research perspective if we really know what that correlation is and can fix it, but there clearly is a correlation. Some people are more likely to have arrhythmia related to, hormonal changes, hormonal imbalances. And then from the point of view of, what else can you do? So, sleep, weight, alcohol, caffeine, hydration. Number of patients do better with magnesium. We find that a lot of patients are walking around with relatively kind of low normal magnesium levels.
And it's responsible for 300 some different biochemical pathways in our body. It's amazing.
And it's natural, and it's over the counter. So if you have kidney problems, you should not be taking too much magnesium because you can accumulate it and it can cause problems. If your kidneys are working well, the likelihood of accumulating magnesium is relatively low. You're gonna, your body's gonna get rid of the extra magnesium anyway. And if you're taking too much magnesium, most people will have diarrhea.
Yeah, of course.
So a lot of my atrial fibrillation patients, we recommend that they take somewhere between 200 and 500 milligrams of, either magnesium oxide or preferably magnesium bisglycinate, which is supposed to have better absorption. And we're aiming for magnesium levels around kind of 0.9 to 1.0 in these patients. Now, is the evidence strong? No, the evidence is pretty weak. But there is some acute evidence in patients who are having hospital, atrial fibrillation in the hospital, that giving those patients magnesium can help control their AFib. And there is soft evidence, on an outpatient basis, but that's kind of part of what we generally talk to patients about.
So we have the lifestyle, we have beta blockers if their rhythm's too high, we have antiarrhythmic drugs like the flecainide or the amiodarone, and those do work, like some of them can work, but it's almost like what is going to work, right? It's almost like a trial and error to see what works with medications.
Since you've mentioned some specific medications, when we talked about rate control and slowing your heart rate down, we talk about digoxin, beta blockers, and calcium channel blockers, generally speaking. And all of these medications, work with some effect to slow your heart rate down. But, calcium channel blockers may also give you low blood pressure. Beta blockers might give you erectile dysfunction and just make you feel tired. And digoxin doesn't work very well when you're active. It only works, at rest. You can very easily become ditch toxic, etc. With antiarrhythmic drugs, you have your sotalol, which is basically a beta blocker, and what we call a class 3 antiarrhythmic. It has a risk of extending your QT interval, which is potentially life-threatening. So if you're older, your kidney function is not that great, you should not be on sotalol. Flecainide and propafenone work very well, but they have this tendency where they can make your atrial fibrillation into a very slow-ish atrial flutter at 150 to 100 beats per minute. But then your heart paradoxically can conduct potentially at 150 to 200 beats per minute, and that becomes a life-threatening rhythm. And so flecainide we don't use by itself. If you have to use flecainide, we typically give it with a beta blocker or calcium channel blocker. So now you're in two medicines. And again, it might work about 30% of the time and potentially make you feel tired. Dronedarone was on the market for a little while. I think it still is. It's kind of a weaker version of amiodarone, actually weaker than flecainide or sotalol, without some of the side effects, but not great for heart failure patients. And amiodarone works. Amiodarone works about 50-60% of the time, but it accumulates in your body. And
I see a question just came out about amiodarone there. So maybe if I can really ask this, is because this person's been on amiodarone for 6 months, and he was in AFib about 2 to 3 times a week for about 30 hours. And he's not been in AFib now for 2 months. So when you say that, I know exactly what's going on. And so, how important is it to get an ablation ASAP and get off of amiodarone? That would be a very important thing.
It's a nice segue. So, amiodarone works well. but it accumulates in your tissues.
Yeah.
And if you take it long enough, it will always accumulate in the eyes. You have to get eye checks. It may eventually interfere with your vision, but 100% of the patients do have accumulation in their eyes. 100% of the patients get it in the skin. And so if you get exposed to the sun, you get sunburn. And if you get repeated sunburns on a myoderone, your skin turns blue, which most people don't generally like.
Yeah.
And then pretty well 100% of the time, if you're on it long enough, it will interfere with your thyroid. You'll become either hypothyroid or hyperthyroid. Now, life-threatening issues with amiodarone, very few people get into problems with their liver or their lungs. Those are rare. Even more rare is an effect where it may affect your central nervous system, and you can get almost kind of tremors, Parkinsonian symptoms, etc. That's very rare, but there is good evidence that early ablation, we've done a study actually, again, led out of Vancouver, but, across Canada, called Early AF, where patients were randomized to either early ablation or antiarrhythmic drugs. And that study, we participated in another study years ago called RAFT. There are a number of studies that show that if you have your ablation done as soon as it becomes a problem, your likelihood of doing well in the long run is much better. There's really no reason other than wait lists for ablation and availability of ablation centers and, physicians such as myself who actually perform ablation. Other than the availability of that resource, there is really no reason to try medication first. Yes, it will work, but you're putting yourself at risk for long-term complications where you could just have an ablation with good evidence to say that earlier ablation, you will be much less likely to progress to more persistent form and permanent form of atrial fibrillation, much less likely to get medication side effects. And to be honest, from the healthcare system, it's much less costly to just go to ablation, even though the ablation itself is relatively expensive.
Yeah. So in this case, because you work on all these drugs and you finally get out of AFib based on whatever cocktail works, then, in this person's question is that, is it better to just get ablation right away?
There is good evidence to say that it's better to just get ablation right away.
Even if they went normal, even if they went normal.
You probably don't want to have ablation after one episode of AFib, right? Because your next episode of AFib may be 10 years later, right? So it needs to be a problem. But then this person clearly was
monitoring it, of course.
Exactly, right? And in this person, having multiple long episodes a week, clearly was a problem, right? The problem is that now if this patient were to stop their amiodarone, they're going to go back into AFib. It's not going to happen immediately because amiodarone has a really long half-life. It stays in your body for 3 to 6 months after you stop taking it. And, but sooner or later, that patient is going to go back into atrial fibrillation. They're only in it because of amiodarone.
When do we use cardioversion?
Cardioversion, I just sort of show a slide here showing a cardioversion. What we do is we put pads on your chest, on the front and back. The anesthetist puts you to sleep for a couple of minutes. We'll give you an electric shock that stops the heart. We want it to stop because we want to restart it, have your normal system restart it in normal rhythm. I don't know if you remember, computers used to have a reset button. Do you remember?
Oh, yeah.
So a reset button was when, you had a virus, your computer crashed, and instead of turning it on and off, you pushed the reset button to reset your computer. We still had the virus. So cardioversion is kind of like that. There are patients where you do a cardioversion and they're in normal rhythm for a long time. But it doesn't eliminate the problem. Cardioversion is just there to restore your rhythm. It doesn't help you maintain your rhythm. It's then up to your heart to maintain your rhythm, either by itself or with the help of medications. We talked a little bit about ablation already, and essentially the technologies we're talking about involve us putting catheters, thin wires into your heart through the vein in the groin. Typically we put you to sleep when we do it, put some freezing around the vein in the groin, put the catheters up to the heart, get them into the left upper chamber. And in this case, this shows us kind of going around each of these veins that drain blood from the lungs into the left upper chamber and burning the area in order to generate scar that would prevent electrical activity from exiting the veins and causing the arrhythmia. In this case, this is a freezing or a cryo balloon that's placed into the vein to freeze the area around the vein. And, these are some of the newer catheters that allow us to deliver this, cool electric field, for the same purpose. When we do an ablation for atrial fibrillation, we generally speaking don't look for pathways. There are lots of different arrhythmias, lots of different reasons to do it. In some cases, there is a clear abnormal electrical circuit that we map, we look for it, and we zap it. In atrial fibrillation, it's very anatomical. We go into your heart, and we want to electrically isolate the veins that drain blood from your lungs into the heart. Some of the time, we want to isolate the area between the veins. We call the back wall or the posterior wall of the left upper chamber. Some patients also have this arrhythmia called atrial flutter. And for atrial flutter, we cauterize or ablate the area between the vein from the groin and the valve between the right upper and right lower chambers of the heart. All right, that's it. Generally that covers about like 90% of AF ablation. So it's not a matter of looking for any specific spots. It's not a matter of looking for specific short circuits. We do that for a lot of other arrhythmias. AFib is very anatomical. We want to make sure that these areas are isolated and electrically silent at the end of the procedure. If you are having atrial fibrillation and you've had trouble with medications, maybe time to chat with your physician again about the potential of doing this type of ablation procedure.
And very quick, and I know if there's any questions out there about where you can get that done, you can connect with us at the HeartFit Clinic, and we can connect you right with their center where you can do ablations pretty quickly as well. And so I know you have a way of getting ablations done very quickly. So if you can just quickly talk about that part, because I get very excited about, not waiting. And
right.
That's very important.
In our case, we've been doing these ablations since I finished my training at the Cleveland Clinic, 20 years ago. At our center, we've grown the program to be doing about 1,000 AF ablations a year. It's one of the biggest, if not the biggest in the country. And we've done a number of things to really optimize the flow of patients through the lab and organization of the lab to where now on a typical day we could do 5 or 6 procedures in one room, and we have 2 rooms doing ablation side by side. So we have a lot of capacity to accommodate additional patient volume. And so recently we've actually created a little website called afibclinic.ca. You can scan the QR code or just dial in the clinic. And it has a lot of information, and we have other teaching materials. We have a number of kind of interviews, conversations, teaching presentations on the various topics related to atrial fibrillation. And it also has a referral form for both physicians to refer patients to us, as well as for the patients to self-refer. For the patients who self-refer, we organize an intake appointment with a nurse practitioner who talks to you, does a little more teaching, make sure that this is the right thing for you. And then if it turns out that ablation is really the way to go, then then we do our best to accommodate that patient at our center. And just to give you an idea, I wonder if I have the pictures here. So what that actually looks like. So we have kind of a prep center here where you come in the morning. You haven't had anything to eat since midnight the night before. The nurse starts an IV. We go through all the paperwork, whatever else we need to do. And then you come into the lab. There's a lot of equipment in the lab. Looks kind of like Starship Enterprise. But I have this big screen. I stand over here. I have this big screen, you're on the table, we have an anesthetic machine, we have an anesthetist there, we have nurses in that corner, and this is where we do the procedures. And just to add, just if you don't mind, just add one extra thing. Some patients with atrial fibrillation also benefit from getting a left atrial appendage occlusion device. And these devices are sort of like corks that we can put into this left atrial appendage I talked about earlier. So typically, these are used in patients who need to be on a blood thinner based on the CHA2DS2-VASc score and the risk for having a stroke. But for whatever reason, they cannot take a blood thinner. Typically, it's because of bleeding either in the brain or the gut that cannot be controlled, and they just can't be on a blood thinner safely. And we're one of the few centers, if not, we may be the only or one of very few Canadian centers where we can do an ablation and put one of these devices in the same procedure. And where that's important is that most of the risk of the procedure is getting you on the table, putting you under general anesthetic, and getting the catheter in the left atrium. Well, we're already there if we do the ablation. So this is just a nice little extra sort of bit of information I think is important for a lot of our patients. So we haven't talked about success rates yet,
Yes,
right?
I know, yeah.
Wasn't avoiding it per se, but
Yeah.
atrial flutter, where we ablate about an inch worth of tissue between the valve and the vein, as I showed earlier, success rate there is about 95% with one procedure. Atrial fibrillation, because it's a much bigger area we have to cover, and because there are people where arrhythmia comes from somewhere else in the heart, we're about 80% successful on average after one procedure. About 20% of the patients may need to have the procedure repeated, and that's typically at least 3 to 6 months out or more. And about 5% may need to have it repeated another time.
Yeah.
And while it's an outpatient procedure, you come in, have it done, takes half an hour to an hour, and you go home the same day. There are risks, so there is a risk of bleeding at the groin, putting catheters in. There is a risk of bleeding around the heart. There's always some risk of a heart attack, stroke, risk to life related to the procedure. So it's not entirely a walk in the park, but again, we do a lot of procedures, and we found that generally speaking, it's very safe, particularly if you do it early. So if somebody is younger, lighter, doesn't have heart failure, doesn't have structural heart disease, the risk of having significant complications is extremely low.
And I'll go back to kind of our gig. It's all about focusing on those modifiable things that you can take care of, to start off with, what you covered earlier there, right? And so, making sure electrolytes and nutrients and all that stuff is balanced properly, and knowing weight is important, hormone imbalances, genetics even come into play with that side of things. So it's important to know those things, I think, to have a better success rate. Thank you very much for your time. I mean, it's such a good conversation. Like I said, I could probably talk another hour and a half with you, because this is all fascinating to me. And, for those of you out there that want to connect more, obviously there's that information there, and look forward to helping you. Obviously, our gig is to help you with your heart health so you can get the success that you want to get out of
so perhaps you never have to see me at all.
Yeah, or maybe not. Yeah, there you go. So anyway, thank you very much for your time today. And
absolutely.
That was fun. Yeah.
Thanks so much, Diamond. Pleasure chatting with you.
Excellent.
And look forward to working with you.
Absolutely. Thanks so much.